Hello, everybody. I haven't been on here in a while. Of course, sometimes when I start my classes, I generally focus on those. Let's see how we can make this stand up. Okay. It might fall. We'll make it stand up like this. So tonight you're going to be joined. joining me. And we're doing tonight's class. We're doing clinical documentation barriers. We're doing that. We're doing clinical documentation barriers. Thank you so much for joining me. And we're having pretty much a live class. A lot of people ask me about my classes. The next class is going to start, I think, January the 15th through April the 16th or April the 18th, 2025. There's going to be another medical coding class that's coming up. The registration will start November the 15th. I'll tell you more about that coming soon. But tonight I wanted you guys to join me as I have my class so you can kind of get a feel of how the classes are if you're interested in the medical coding classes. Again, this class is for nurses who's looking to get away from the bedside, looking to work remotely in the HIM or Health Information Management setting. This class is also for those who have jobs and want a career. This class or course or medical coding is for those who feel like they are overworked and underpaid. One of the things that sold me on getting into medical coding was the fact that it was a short period of time. Because at the time, I didn't want to go back to school to get another degree or anything like that. So it's a short period of time. You can make great money, and you can use your book for the exam. You can also write notes in your book, and you can refer to those notes while you're taking the exam. So I was thinking to myself, wait a minute. I can use my book. I can make good money once I'm certified, and it doesn't take a long time. So that's where we are with it. Just a minute, grab my book for class. So, join me as I have a class session. Okay, we have more in here. We'll go ahead and start. So, before we start on chapter 8, let's go back and review to make sure that we are retaining the information. So when these patients get their RAF score, we know about RAF, risk adjustment factors. When they get their RAF score, in addition to their diagnoses, because that's the main thing. So addition to their diagnosis, what are other things that are factored in when these patients have their RAF scores? Somebody name some things. You can name them out loud. Name them out loud for me instead of put them in the chat box. What are some things that are factored in addition to diagnosis codes? I can't hear you. Can you say that again?
The age.
Age. Okay, that's one. Age. Somebody else? Anybody else?
The gender.
Gender. Perfect. Age, gender. Anything else? You got to refer back to your notes. Say it again.
Is the insurance status?
Insurance status. Perfect. We have a few more.
Disability status.
Disability status. What else?
Socioeconomic.
Socioeconomic status. Okay, we have two more. I love this. You're retaining the information.
Claims data.
Claims data. Absolutely. And one more.
Place of service?
Place of service.
The claims data, ain't it?
Yeah, that's on the claims data. Yes, the place of service goes with the claims data. So the last one is kind of tricky.
Special patient conditions.
There we go, Ms. Bird. There we go. Special patient specific conditions. For instance, if they're on hospice or if they have end-stage renal disease or end-stage kidney disease. And when a person has end-stage kidney disease, they have to be on... What they have to be on? Dialysis. Thank you, Ms. Fanta. dialysis. So there we go. So again, factored into that RAF score is going to be, addition to the diagnosis code, is going to be your age, gender, socioeconomic status, disability status, insurance status, claims data elements, and special patient-specific conditions, like if that patient is on hospice or if they have end-stage renal disease. It's very important to risk adjustment. Okay, great question. So I'm being repetitive on this because there are going to be several questions on the exam about this. And I know sometimes people say, Marciana, you're being so repetitive. And I also have people say, when I was sitting for my exam, all I could hear was your voice in my ear. That's why I'm being repetitive with all these things that I know that they're going to be on the exam, because I want you to have these embedded in your mind. What is the risk adjustment model for Medicaid? Go back in your notes.
HCC-C.
That's for Medicare. So that was a good try. That was for Medicare. So remember that.
CDPS.
That's it. CDPS. So for Medicaid, it's CDPS. And Ms. Shawn, she said that it was HCC for Medicare. So what is it for commercial insurance?
HCC.
And HHS.
There we go. HHS, HCC. There we go. You have to put that Health and Human Services acronym, HHS, when we're talking about commercial. Perfect. Okay. So somebody name me 2 approved providers and name me 2 providers that are not, well, not so much as providers. Name me 2 providers, 2 approved providers. So in risk adjustment, we cannot just look at certain notes from certain people who are delivering care. But give me 2 providers, their titles, that we can look at their notes and we can factor that into their risk adjustments, these patients' risk adjustment score.
Is it psychiatrist?
A psychiatrist is definitely one.
Medical doctor, MD.
There we go, an MD, a medical doctor, psychiatrist, speech therapist, occupational therapist, physical therapist, absolutely. So psychologist, MD, definitely one. Again, RNs, LPNs, MA notes or whatever, we cannot code from those. So again, general practice, general surgery, allergy doctors, MDs. So she covered that with MDs. Speech language pathology. That's one. Physical therapy, sports medicine, pathology, psychiatry. All of those are one. All of those are approved providers. Perfect. So I just want to do a quick review. And before we end today, we're going to have ICD-10 questions as well. So we're going to go over ICD-10 heavily next week, which is going to be our last official lesson. But of course, after we have our lesson, we're going to have the last session that's going to be a complete review of everything we've learned in these 12 weeks. And then we're going to write notes in our book. So what I learned when taking this exam, and just from just being in this field, just in general, when it comes to taking exams. You know, I've taken 2 coding exams. I have 2 certifications, and I'm working on a 3rd one right now to have by the end of the year. But when we're writing these notes in our books to refer to, you don't want to be scrambling all over your book. You don't want to be scrambling all over your book when you're taking the exam. It's already going to be a stressful situation. You want to be able to look in your book and say, because this is another thing that I did also to help the students who take this class, to help you guys, how I have the class set up. Chapter 1, Chapter 2, Chapter 3, all the way to Chapter 9. This is the exact way that it is set up on the exam. This is the exact way, the exact section. So when you get to your exam, you get to Section 1 on your exam, it's going to be professional coding and all the information about that. When you get to Section 2, it's going to be medical terminology. When you get to Section 3, it's going to be ICD-10. So I set it up in that way where you can write your notes in your book, and it's set up the same way as the exam. So next week, our last chapter, Chapter 9, we're going to heavily focus on these chronic conditions. We're going to heavily focus on these chronic conditions and coding. So we got our introduction, I am pulling up the lesson now. So, we got our introduction to ICD-10 and coding in chapter 3. So there was an introduction, so you'll know exactly how to code, certain guidelines, what to do, things of that nature. And so now when we get into chapter 9, we're going to heavily focus on that. On your exam, you're going to have 10 case studies. It's going to be at the end of your exam. Some people like to do those first. I'm not sure on the electronic exams if you're able to do so, if you're able to skip around. However, going through the cases are going to be very, very important for us on next week, because those cases are pretty much documentation from providers, and we have to thoroughly go through the documentation to make sure that we're selecting the right codes. We're also going to go through a process of elimination. A lot of times it just makes sense where we can look at these codes and we can say, oh, this is automatically not the answer. So that's what we're going to focus on next week, process of elimination. Let's see here. We're going to focus on process of elimination and knowing how to choose the correct codes. So let me bring the lesson up. How has everything been going for you guys when you're going through the lesson? How are you guys doing on the quizzes? Because I can't pull up everybody's individual quiz right now. So how are you guys doing on the quizzes?
Okay, I guess.
Are you passing?
Guessing myself a lot.
Okay, so that's a thing that we typically do when we're just learning these things. On the exam, try not to second guess yourself. Thoroughly read what they're asking you and remember to answer what they're asking you. Nothing more, nothing less. So it's quite natural to second guess yourself. Anybody want me to reset their quizzes or anything, just always send me an email. Let me know so I can reset your quiz. So this chapter will discuss common documentation barriers in risk adjustment coding. A professional coding working in this field of risk adjustment must be vigilant about updates to ICD-10 guidelines and code sets, as well as AHA coding clinic. Anybody familiar with the coding clinic? So let me explain the coding clinic. Let me put it in pretty much layman's term. When we're sick or we need to check out what's going on, we're going to go to the clinic. We're going to go to the doctor's office. So pretty much coding clinic is where you go to get your coding information. If you're second guessing things about it, you can just Google coding clinic. And if you're second guessing yourself, like, I'm not sure if I'm supposed to use this code in this scenario, you can always go to coding clinic and it's going to verify if you're using the correct codes or not. So right now we're going to talk about signature and credentials. So provider signatures are important to proper documentation or accurate documentation, adequate documentation. And without it, the documentation is incomplete. It is an expected element of payment, being that if your documentation is not clear, if it's not legible, if it's not accurate, then your payment is not going to be accurate. And we know that healthcare is about, making sure sick people get their management, their treatment. But healthcare is also about money. It takes money for healthcare to roll on and on. So we, as coders, are here to make sure that the documentation is adequate. We're here to make sure that the reimbursement, that the money they're supposed to receive for rendering care to these patients are received. So CMS requires that medical records be signed in a timely manner. The timely manner may vary from payers, from whether it's commercial, it's Blue Cross, it's Humana, it's all of these different Medicaid. So, but they have 30, 60, 90, or even 365 days to sign their documentation. Most companies, most providers or practices or hospitals, they have a tight window. All the places I've worked when it comes to medical coding, when it comes to HIM or health information management, most providers have up to 5 days. Up to 5 days to sign their medical records. Although these payers give you 30, 60, 90 days, that company does not want you to wait or want that provider to wait 30 days, 60 days, 90 days to sign their documentation. So, again, we talked about back in the day, they will pull your records from a paper file. They'll pull out the file cabinet or they will have it on the shelf. And nowadays, when you go into the doctor's office, they're typing in whatever you're coming in for. They're typing in whatever you're saying is wrong with you. So now we have electronic health records, where our health records are stored electronically and not in paper files. So when we talk about signatures and when we talk about the medical records must be signed in a timely manner, let me give an example. So if a patient is coming in to see the provider, coming in to see the nurse practitioner, the physician assistant, the MD, they're going to say, 23-year-old patient comes in, she's coughing, sneezing, she has fever, chills, we're going to give her a flu test, we're also going to give her a COVID test, things of that nature. That documentation has to be signed. Signing that documentation pretty much says that this provider is the one that saw this patient, and this provider saying that everything in this medical record is accurate and true. Okay. Any questions about that? No questions? Okay. So an addendum and adding a signature later is different. Now get this, there's an addendum and then a provider can add a signature later. Two different things. Addendums, and I'll give you an example of addendums. Addendums to include patient information and usually must be added within 60 days after the encounter. Some organizations have a shorter time frame, 7 to 14 days or 30 days. The longer the clinician waits, the longer it is to recall the details of the encounter. So just like, a lot of us can't remember what we were doing on September the 30th. It's our memories sometimes get fogged when we wait a long time for certain things. So same thing in healthcare, same thing with these providers. If you don't add certain things in a timely manner, it's going to be harder or more challenging for you to recall the details of that encounter with that patient. Let me explain an addendum. Let's say a patient is coming in for lab work. They're coming in for a CBC, which is a complete blood count. They're coming in for a CMP, which is complete metabolic panel. They're coming in for a TSH to check their thyroid, things like that. So when they're doing the labs, your medical assistant or whoever's there is, or a nurse, if they have a nurse to do it, they're going to draw your blood on the day of that encounter. Sometimes practices have inpatient labs. Some practices have labs inside of their facility, not inpatient, because inpatient is hospital. They have their labs there, of course. But when you're going to your doctor's office and you're getting your labs drawn, sometimes these doctor's offices or practices, they have in-house labs. Sometimes they have to send them out to LabCorp or Quest or any other lab services, and they have to wait for the results. So, of course, when that patient comes in for labs, they're not going to immediately have their results on that same day. So the patient is going to say, hey, 55-year-old man that has diabetes, we performed an A1C to see what his A1C is. A1C is fairly high because he has diabetes, of course. A1C is 9. So we're going to give him some things to control his diabetes. We're also going to give him other lab tests. We're going to give him a CBC. We're going to give him a CMP. We're going to give him a TSH because we feel like he has thyroid problems. He's lost a tremendous amount of weight in a short period of time. So we're going to give him a TSH test as well. So once we give them the TSH, the CMP, the CBC, they're going to send it to the lab. So then this addendum is saying that this provider has about 7 to 14 days or even 30 days when the lab results come back to add the lab results into the medical record. That's an addendum. That means you're coming back at a later time and you're adding things that happened at that visit that was not able to be added at the time. Any questions about that? Any questions? Okay.
Marcy,
Yes.
you're not sharing your screen.
Oh. Nope. I'm going through it. And nobody, y'all gotta say so. Y'all better tell me. Okay, so let me go back. Boom. Here. Okay. Thank you so much. Do this. And let me know, you guys, if you're able to see it now.
Yes.
Perfect. Okay. So as you see here, provider signatures are important to be, has to be accurate for reimbursement. CMS requires that medical records be signed in a timely manner. An addendum should be added in a timely manner as well. And understand, an addendum, and later adding your signature, or adding the provider adding their signature, that's two different things. So now let's talk about CMS guidelines on signatures and credentials. Medicare requires the signature and credentials to be legible. Sometimes when we have, because I'm a provider educator now, so I work with a lot of providers. I had this provider before, and it was maybe, when was this? This was when I was traveling back and forth to Florida doing EMR implementation, and this provider, he was an older provider. So he had been a physician for maybe, I think, 38 years, 41 years or something like that. He still couldn't get into the transition from handwritten charts to electronic. Again, a lot of us on this call are old enough to remember when we used to go to the doctor's office and they would pull out a chart out of a file cabinet, or they would pull out a chart off of a shelf. So those doctors were handwriting their documentation or their notes. So again, now we have what we call electronic health records, where all of our health records are safe, secured electronically in systems. So Medicare requires the signature and credentials to be legible. If it's handwritten, it has to be legible. If it's not legible, it's going to be a problem. In electronic signatures, it's always going to be legible as well because it's electronically transferred. The name of the treating provider must be legible near the signature. So when you're looking on a medical record, and you guys have examples of what a medical record look like, when we're looking at the medical record, whoever treated that patient, their signature must be near, or the treating provider must be legible near the signature. Or the printed name must be presented somewhere on the medical record. And it's usually at the header or the footer, at the top or the bottom of the documented record. So if you have a provider who's still doing, and these companies are allowing, these practices are allowing them to do handwritten documentation, make sure that the handwriting is legible. And let me tell you how it goes when you're on the job. If you're on the job and you're in your EMR or your system and you're coding, you're reading documentation and you're coding, if you see a handwritten signature that is not legible, what they typically do is, for SOP or standard operating procedures, they'll have you email or send that documentation or send that medical record to your supervisor and let your supervisor know that you cannot make out the handwriting on this documentation. You don't have to squinch and try to read and try to do these things. You let them know, hey, I can't read this. You send it to your supervisor and that's it. Also remember this, write this as a note because this is important. I always tell you what's important, and what you need to write as a note. The treating provider, meaning the provider that treated the patient on this visit, is the only provider who's supposed to sign this documentation. How can another provider at that doctor's office sign this record and you didn't see the patient? So remember that the treating provider has to have their signature on the medical record of the patient that had the visit with them. So without the signature on the date of service encounter, in some instances, you can still code the chart and flag it for missing signature. These diagnoses are still factual. So let me give you an example of how that goes when you're working on your job as a medical coder. So you're looking in your EMR or your charts that they've assigned to you for you to code. And you're looking at this chart and the signature is missing. Most times, and every company is different. I've worked for different companies and their procedures are different. But typically, just because the signature is missing, that does not mean the diagnoses or the things in this medical record are not valid. It's still valid, it's just missing a signature. So what some companies will have you do, although it's missing a signature and it has to have a signature, we'll go ahead and code the chart. We'll flag it to our supervisor, let our supervisor know that the signature is missing. Then that supervisor will get it to the provider so the provider can sign it and we can send it all off to get paid for it. So that kind of speeds up the process instead of having this chart in your queue and we're waiting on the signature and it's not coded. It's just sitting there. It's waiting. So they'll have us go ahead and code it, flag it to the supervisor. The supervisor will get it to the provider. The provider will sign it and will send it off to the insurance company to get paid for that specific patient. Any questions? So again, for every date of service encounter, every date of service, and somebody tell me, what is date of service? What does that mean? DOS is going to be the acronym. What does date of service means?
The day the patient was treated.
Absolutely. Absolutely. The date that the patient had to visit, or the date, like Ms. Cheryl said, that the patient was treated. Perfect. Okay. So detailed acceptability of signatures. Detailed acceptability. So, because some signatures are not accepted. So if you guys remember this, and some people have worked in healthcare settings on this call, and some people have not been in a healthcare setting at all, but you might have, saw it. So who remembers signature stamps back in the day? Who remembers that? Would the doctor just get a stamp, boom, and signature like that? Anybody remember that?
I do.
Okay. Anybody else remember signature stamps?
I do.
Okay, I was going to say, don't make me feel like I'm the oldest person on this call now, like I'm the only one remember some signature stamps or something. So, yes, signature stamps are not acceptable because anybody can take that stamp and stamp it. So, as time has progressed, healthcare has become more secure. They understood that having patients' information in a file cabinet or having patients' information on the shelf in the doctor's office, that's not secure information. What if somebody breaks in the doctor's office? Or what if somebody, does something and takes it home? We're not sure who committed that crime, who did that. So now as time progresses, healthcare is becoming more secure by the year, by the month, by the minute. It's becoming more secure. So signature stamps, anybody can pick up their stamp and stamp a record and documentation. And their provider probably, couldn't have done it. So detailed acceptability of signatures. Handwritten signature or initials of treating providers, they're accepted. Electronic signatures are accepted. And electronic signatures happen when they're inside of their EMR or EHR, electronic medical records, or electronic health records. They're simultaneously. Like I can say doctor, I can say physician. I can say lawyer, I can say attorney. I can say you're an educator. I can say you're a teacher. I can say I have children. I can say I have kids. So EMR and EHR are simultaneously, it's the same. So let's talk about signatures that are not accepted. So if you see these things in your queue when you're pulling up your medical records and you're coding on your job, you can flag it and let your supervisor know, oh, this is a signature stamp. I know this is unacceptable. So unacceptable signatures are signature stamps, not acceptable. If the medical record has been dictated but not signed or read, it's not accepted. That means that the provider wrote it up, whatever, but they didn't read it or they didn't sign it. That's not acceptable. Has to have a signature. Signed but not read is not acceptable. And these are things that you should write down, or make sure when you go back and get into this chapter inside of the module, make sure you take these notes down. These are notes that we are going to have to write in our book because there's going to be questions on the exam about acceptability of signatures. So if it's signed but not read, it's not acceptable. If it's signed by someone other, we just talked about this. If it's signed by someone other than the treating provider, it is not acceptable. Does anybody need time to write this down before I go to the next slide?
Just a little bit.
Okay, no worries. That's why I asked. Let me know when you're done. Let me know when I can move on. It's for anybody that's right.
Okay.
So again, the green, these are acceptable signatures. Everything on the right side of this slide, not acceptable. You know how we was talking about RADV audits, risk adjustment, data validation, those audits by Medicare. If they see a signature stamp, that's not acceptable. If it's signed by someone other than a treating provider, not acceptable. And someone may ask, how do you know it's signed but not read? It's going to be in your EMR, your EHR, whichever you prefer to say. It's going to say that the provider signed it or they dictated this, but they didn't read it. It's not acceptable.
Oh, okay, I'm good with it.
Okay. RADV, HRADV, and signatures. So who would be conducting, or what model would be conducting HRADV audits? You remember that? What form or what type or what model, what risk adjustment model uses HRADV?
Medicate.
HRADV. Who uses HRADV?
Medicate.
Commercial.
No.
Commercial uses HRADV because the H stands for Health and Human Services. So just like we have HHS, HCC, HRADV is for commercial. RADV is for Medicare. Okay. RADV audits are conducted by CMS to validate and verify the accuracy of coding. Medical records must support the diagnosis used. So when Medicare has their RADV audits for risk adjustment providers, which is conducted by CMS, they're looking to validate, because keep in mind, CMS has paid this insurance company, or had for their Medicare Advantage plan, has paid this insurance company for these diagnosis codes. So they're going to go back and they're going to verify that these diagnoses should be used. And CMS is going to make sure that you didn't just put these codes on a chart to get our money. We're going to make sure that it is supported by the documentation. The best example I can give, or the simplest example that I can think of, if you're saying that a patient has diabetes, their A1C has to be somewhere in their documentation to support that they have diabetes. If you're saying in the medical documentation, or if the provider is saying in the medical documentation that this patient is on insulin for their diabetes, then we have to show in their medical record that this patient has been prescribed insulin. So again, RADV audits are conducted by CMS to validate and verify the accuracy of coding. Medical record must support the diagnosis used. You just can't use the diagnosis and there's nothing there to support that you're using it. It's like, what, you made it up? Did the provider make it up? So where's the support to use this code? So this is going to be important as well, because there might be a question on the exam that says RADVs are conducted by CMS for, and you're going to say to validate. It's going to be, of course, multiple choice, and you're going to choose the answer that says it validates and verify the accuracy of coding. So all dates of service must include the signature of the treating provider. Provider's printed name is not required if you can legibly read the signature. The title, this is important, the title doctor, that's not accepted as a credential. So when we say the credential has to be there, are you an MD? Are you a DO? Are you a speech language pathologist? Are you a PT, which is a physical therapist? Are you an OT, occupational therapist? So your credential must be on that medical record. Must be. And it can't say Dr. Smith, a Dr. Elaine Jones. It cannot say that. It has to be Elaine Jones, MD. Elaine Jones, DO. Elaine Jones, speech pathologist, speech language pathologist. Elaine Jones, OT. Elaine Jones, PT. It has to have your credential. Doctor is not acceptable. Think about it this way. Some people can have their doctorate in health information management. Am I a medical doctor because I got my doctorate? No. Am I able to, if I have my doctorate in health information management, am I able to treat patients? No. So doctor is not an acceptable credential. Signatures can be requested and obtained during the attestation of an audit. So we're doing these RADV or these HRADV audits, and the auditor says, whoa, I'm reading this medical record and the signature is missing. Then their provider can go ahead and add their signature. It won't be a ding or a penalty or anything. They can add their signature during the audit. So inpatient records. What setting is inpatient? Is it a doctor's office or is hospital? Hospital. We have inpatient, outpatient. Inpatient means you're in there. They have admitted you. Outpatient, you can walk in and out. You can have outpatient surgery. You can have same-day surgery. That's considered outpatient. even if it occurs at a hospital. If you're in and out same day, that's an outpatient procedure. Inpatient records are assumed to include signatures because all hospitals adhere to JCO standards. JCO is a credentialing body pretty much for hospitals. So you know how we're looking in the outpatient setting, make sure the signatures are there, whatever the case. In an inpatient setting, it is automatically assumed that the signatures are there because the hospital adheres to standards that the signature has to be there. Any questions about that? No questions? Okay. Okay, attestations. In general, attestation is the process of validating something is true. A healthcare organization must demonstrate meaningful use in order to be eligible for payment from the federal government under either Medicare or Medicaid, their EHR incentive program. CMS will not allow separate attestation for any diagnosis. It must be documented in a face-to-face encounter. So everything is pretty much face-to-face, and you're going to hear or you saw or heard throughout this course face-to-face a lot. Remember, prior to COVID, there weren't really any telehealth visits. Would you guys agree or disagree? That you probably hadn't even heard of a telehealth visit until COVID.
I agree.
So telehealth visits and virtual visits became very, very popular when COVID came around. A lot of doctors' offices was closing because they didn't want other patients to get COVID-19. So that made it a way where we can do virtual visits as well. And they count it as the same as face-to-face. So CMS expects all date of service to include, now write this as a note, very important, you're going to see this on this exam. CMS expects, and it's great to know CMS expectations, their guidelines and things for this exam. So CMS expects, not want you to do, not would like for you to do, they expect all date of services to include the treating provider's signature, the attestation for each visit. Provider's printed name is not required if the signature or attestation is legible. Or attestation is legible. So if you have an electronic signature, then they're not going to make you have a print signature because everything is done electronically. So attestation for each visit. Provider's printed name is not required if signature or attestation is legible. If illegible, more than one provider listed, identify the provider, the treating provider, and their credentials. So let me know when you're done writing that. So I'm going to read something from the AAPC that they've provided. And we're talking about inpatient signatures and things of that nature. So in 2010, the communication, and we're talking about JCO, the Joint Commission, that's what JCO is, that requires hospitals to ensure all entries in the medical record are not, they are to ensure all entries in the medical records are not only signed, but also dated and timed on complete and accurate medical records. It's the most important of all record-keeping standards. Although the Joint Commission doesn't spell out in detail every field and item that must be included in a patient's chart and medical record, it emphasizes that hospitals must make full use of each record per their own design, whatever EMR they're using. Let's talk about past medical history. So it's common for providers to list both past and current diagnoses on the medical record. It is very common for a provider to list their past medical history, as well as the current things that are going on with this patient. So you can answer this out loud, you guys. If I see something on the medical record that's under the past medical history list, can I automatically assume that their condition still exists and coded?
No.
No. I have to have documentation in that encounter that condition, that disease still exists. You can't just pull off the medical record and say, oh, okay, pull off the past medical history and say, oh, this patient has, let's see something that resolved. This patient has a pulmonary embolism. That can be resolved and there can be history of. So it's very important to know what is active and what you need to use a history of code for. Primary example that I can think of off the top of my head, breast cancer. A lot of providers, and just to us, and we're coders. So when we see the phrase or the wording, patient has history of breast cancer, we're automatically to assume that when they say history of, then that means that disease is gone, it's eradicated, they don't have it anymore, they're not being treated for. Providers in their mind, and that's why provider education is so important. So we can align, because sometimes there's a disconnect, between providers and coders. It's like, for an example, I'll name countries, Mexico, Brazil, those countries, they speak Spanish, but it's a different dialect. So it's like coders and and providers, we speak the same language, but sometimes it's a different dialect. So when they say history of, when providers write history of, they feel like they're telling us what the patient's current history is. But when we see the word or hear the word, oh, history of, we automatically assume, oh, they used to have it. They don't have it anymore. So that's why it's important that we have the documentation in the record to shows or to reflect that if it's truly a history or if it's still current. So how you know with breast cancer, and I'm going to say it over and over again because this is going to be on the exam. They're going to try to trick you. This exam is not laid out in layman's terms. Well, oh, okay. No, they try to trick you. So that's why I say pay more attention to what they are asking you versus how they're asking it. Pay attention to what they're asking and not how they have worded it. So if I see a provider say patient has history of breast cancer, and I also have blah, 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 the first thing I'm going to do is I'm going to look at the medication list. I am going to see if there are any medications for breast cancer. I'm going to look at it to see if they have any oral medications. I'm going to look through the whole entire record to see if they're on chemotherapy. I am going to look and see if they're on radiation. I am going to see if the cancer has been excised. Did they take it out? Or is it truly over? So how I know if they do not have breast cancer anymore, I won't see any treatment. So if they say a patient has a history of breast cancer, for me to know that it's truly a history, then I do not see any medications. I don't see any treatment. That's how I know it's a true history. And I'm going to use a Z code. We know our Z codes are our status codes. It shows us the status of things. So if I see that the provider says patient has history of breast cancer, and then when I look into the medication list, oh, they're on chemotherapy. Current chemotherapy. They just had their last chemotherapy session 2 days ago. So I know that is still current because they are being treated for it. If they say patient has a history of diabetes, oh, I see insulin. That means it's not a true history. I need to code it as current. Because we know that our breast cancer codes is C50 dot whatever. And our history of breast cancer code should be Z85. I'm not looking in my book, but I kind of know my codes. It's either Z80 or Z85. Somebody confirm for me. I'm thinking Z85.3, but it could be Z80. So somebody confirm for me, what is the history of breast cancer code? Somebody confirm it for me. What is it? Say it again for me, Fanta.
It's Z85.3.
Z85.3. I know my codes and I'm not even looking in the book. So Z85.3, you're going to use history of breast cancer when someone has a history and they might have had a mastectomy, had their breast completely removed. Both of them removed, one removed, or they got the cancer cut out and there are no more treatments. That's how you know it's a true history. That's how you know. So status codes are generally your Z codes. Our Z codes are in the back of our book, and it reflects the health status of the current patient. and it allows qualified healthcare professionals to gather a complete picture of the patient's current and past health ailments. So, family history is very important. Family history, any past medical history that a person has had is important. Family history is important because if a person's great-grandmother, their grandmother, their mother, their sisters, if they have all had breast cancer, then it's hereditary, and it could be likely that this patient is going to have breast cancer at one point in their lives, or it also helps for preventative measures. Instead of getting a mammogram every 3 years or something, this person might get a mammogram every year because they have a family history of this type of cancer. So family history is very important. Patient's history is very important. For example, remember, we're going to always code the old MI. Old MI. Somebody tell me what an MI is.
Heart attack, myocardial infarction.
Thank you. Heart attack, myocardial infarction. Remember that. If you don't realize that, make sure you write it down. MI is myocardial infarction, and that's the same thing as a heart attack. So if someone has a heart attack before in their lifetime, it could be 6 years ago. We need to know that sometime in this patient's life that they've had a heart attack before, because they might be susceptible to having another one. So someone look up the old MI code for me, and it should be correct. I'm not sure. But see if the code is I as in igloo 25.2. Tell me if that's old MI. I 25.2.
Yes, ma'am.
That's correct?
Yes, ma'am.
Okay, perfect. So somebody tell me, when do we code an active heart attack, and how long does it take us to code that old MI? How long does it have to be for this patient to have had a heart attack where we use the old MI code?
I let them answer first.
Okay, say that again.
I said old was 4 weeks.
Absolutely. If the heart attack is older than if they had it 4 weeks ago or more, then it's considered an old heart attack. If it's less than 4 weeks, you're going to always use the acute code for a heart attack. And that should come from the category I-21. Can someone look and confirm for me? I-21, that should be active or current or acute MIs.
I just want to let them answer first. It's correct.
Okay. Thank you so much. Thank you so much for confirming it for me. So the heart attack, and this is going to try to trick you on the exam as well. Also, let me show you some things. Let me go in my book because I would like to show you some things about your book. Everybody turn to I-21. I-21. Okay? Do you see, and let me know when everybody get there. You just let me in the chat box. You can just say I'm there. I'm going to have y'all say I, me. Okay, when you get to I-21. I'm sorry, y'all did tell me. I just didn't look in the chat box. Y'all did tell me that we can't see the PowerPoint. So everybody let me know. If you have the 2024 book, it's on page 685. 685 in the most current ICD-10 book. Okay? There. 685 in the newest edition. Perfect. Okay, waiting on a few more people to let me know that they are there. A few more people to let me know they're there. Perfect. Okay. Perfect. Okay. So you see where it says acute myocardial infarction. When you look down a little further, it says it includes. Sometimes the provider can put a different definition or a different phrase or saying. But understand that everything that's under this includes, make sure you're looking at this on the exam when you're looking up your codes. If it says cardiac infarction, that's the same thing as an MI. Coronary artery occlusion, this includes that. This includes that. So if it says that a patient has had a heart attack and coronary artery embolism, then you know that's all included in this MI code. Also, look where it says use additional code if applicable to apply. If they have had exposure to environmental tobacco smoke, secondhand smoke, history of tobacco dependence, occupational exposure to environmental tobacco smoke. So make sure if you're reading a medical record and it says the patient has had an acute myocardial infarction, and when you look up under the social history, it says patient is current smoker. Then you know that patient is current tobacco chewer. You know that you're going to use this tobacco use also in this code. So make sure you're looking at what is included, and make sure you're looking at the things that are synonymous with the code that you're looking for. Any questions? Questions? No. Okay. These Z codes or our status codes can often be overlooked and need to be captured at least once a year. It needs to be captured at least once a year. We talked about that. Do you guys remember? And if you guys here on TikTok have any questions, then make sure you drop the questions in the chat box about this medical coding course. Any questions? No. Okay. And again, these Z codes can be often overlooked and need to be captured at least once a year. These Z codes are important. Just because some of these don't risk adjust and they don't have an extra added reimbursement to those, they're still important to know for the health status of this patient. Again, to show the complete picture of the patient's current and past ailments. Permanent and long-term conditions such as transplants, current ostomies, and amputations are currently found in this category and reflect the financial need for management. That means if a patient has had a transplant, if they have an ostomy, like for example, a colostomy bag, where they have to, the defecation goes into this bag and they have to change it. If they have any amputations, these are Z codes, but these are Z codes that are attached to reimbursement. A lot of these are overlooked and left out. So if you're reading a medical record, yes, patient comes in, yeah, they've had a transplant, 2019. You need to have a history of transplant. Yes, patient comes in, patient has an ostomy. You need to notate that the patient has an ostomy. So let's go to Z93.0. Z93.0, I think this is it, Z93.0. There should be a tracheostomy. Somebody tell me what that is. Z93.0. Is that tracheostomy?
Yes.
Yeah, so there should be status of tracheostomy. Am I correct?
Yes.
Thank you. Let's see. See, when you guys get to coding and stuff, you're going to remember these codes just like I remember these in the back of my head. I remember these codes like I know my son's social security number. So let me go so I can give you an example of what I'm talking about. What I said, Z93.0. Z93. Okay. Z93.0. So tracheostomy status. Tracheostomy status. There's a difference between attention to tracheostomy and tracheostomy status. So let me look at this code. I'm thinking it's Z43. Let's see if I'm correct or not. I'm thinking it's Z43.0, where it should be attention to tracheostomy. So let's see. I might be wrong. Let's see. I may be wrong. Z43. Nope, Z43. I am correct. So I want you to maybe put a pencil, pen, piece of paper or something where it says Z93.0 for the status of tracheostomy. Then I would like for you guys, because we're going to flip back and forth, we're going to toggle back and forth. So I want you guys to go to Z43.0. That's on page 1320 in your 2024 ICD-10 book. 1320. Z43.0, and let me know when you guys have it. Z43.0 is encounter for tracheostomy. So someone other than Fanta, I want you to explain to me the difference between Z43.0 and Z93.0. Kind of explain to me the difference of the codes, or tell me an example of when we would use each code. Anybody want to volunteer? If nobody volunteer, I'm going to tell the answer. But anybody want to volunteer? Take a stab at it, even if you're wrong.
The second code, I'm sorry. The Z.
Volunteer. If nobody volunteer, I'm going to tell the answer. But anybody want to volunteer? Take a stab at it, even if you're wrong.
The second code, I'm sorry. The Z.
Volunteer. If nobody volunteer, I'm going to tell the answer. But anybody want to volunteer? Take a stab at it, even if you're wrong.
The second code, I'm sorry. The Z93.
Z93.0 and Z43.0.
Okay.
Somebody take a stab at it. Even if you're wrong, that's okay. Because the whole point, if you already knew the answers, then you would not be in this class. So if you're wrong, that's okay. I'm here to give you the correct answers, but at least try and take a stab at it and tell me the difference in these codes.
Z43 it says encounter for the attention to, meaning that is the reason for their visit.
Absolutely.
And Z93 is just the status of, meaning they, had it already and the doctor noticed.
Oh, perfect. So let me detail it even further. Perfect answer. So let's say a patient has hypertension, and this patient is going into the provider to follow up on their hypertension. However, this person does have a trach in their throat, in their neck. They does have a trach. But they're not going into the doctor's office for the trach. They're going in for their hypertension. So if this patient goes into the doctor's office to follow up on their hypertension, the provider just notices that they have a trach. So they're going to put status of tracheostomy, just to notate that they know that this patient has a trach. So they're going to use the code Z93.0, where they're not going to use the code. They're going to document and say, patient comes in to follow up on patient comes in to follow up on their hypertension. We're going to refill their amlodipine. Patient also has tracheostomy. So the doctor just notated it. They didn't touch it. They didn't look at it. They didn't do anything to it. They just see that the patient has it. So that's when we're going to use status of tracheostomy, because it's just showing, our Z code shows us the health status. It's just showing that this patient has a trach in their throat. So when we use the code Z43.0, encounter means you're going to the doctor's office, you're going for a visit. Encounter for attention, you're paying attention to it, tracheostomy. That means that the trach, this patient has been at home, the trach has got clogged up, the trach has come out a little bit. They need to go and see what's going on with the trach. It's not operating properly. So when that patient goes into their doctor's office, they're going in and their chief complaint is going to be tracheostomy clogged. Tracheostomy is not working properly. So that means that they had this specific encounter for the trach. So that's when you're going to use encounter for any of these ostomies if they're going in to get it checked on. So past medical history again. I keep bringing it up because it's the whole basis of when you get on this exam, that some people tend to code from the past medical history list, and we cannot do that if we cannot show in this documentation that condition or that disease is still current. So sometimes providers will list both past and present conditions in the portion of the medical record. When the provider uses the term history of, be sure that there is not current ongoing treatment for that specific condition. Check the medication list in HPI, which is your history of present illness. The part, let's see. Let's see. Give me just a minute. Just a minute. Give me just a minute. Okay, perfect. So sometimes providers will list both past and present conditions in this portion of the medical record. When providers use the term history of, be sure that there is not current ongoing treatment for that specific condition. Check the medication list and the HPI. We know the HPI is the portion of the medical record where they say 99-year-old black female comes in. She has end-stage renal disease. That's the HPI part. That's their history. And it sounds contradictory because it says history of your present illness. And it's really just a history of everything that is presently going on. So you're going to check their medication list and their HPI to locate supporting documentation for the diagnosis is coded, applied to the medical record. Familiarize yourself with diabetes mellitus, hypertension, and heart failure medication. So, of course, we can't remember all of these things, but when we go and have our session to write things in our book, we're going to have us a medication list as well, so we can write down, and then it's going to be like the most popular or most commonly used medications for certain diseases and conditions. So, lab and diagnostic test results. Before we go, I need an answer from everybody. Can we look at the lab results and code and make a diagnosis code and write a diagnosis code from the labs that we read?
No.
No. Lab and diagnostic tests, we're not going to code from them unless the lab is pathology, because pathology tells us if they're stage 1, 2, 3 cancer, or if this tumor is uncertain behavior. We don't know what it's going to do. If it's... we don't know what's going on, but pathology can tell those things. So we're not going to code from lab work, like the blood draws. We're not coding for that. Because let's say a person comes in a doctor, they get their A1C checked, and the A1C is all out of whack. It's a 13. This patient could have eaten a lot of sweet stuff before they got to the doctor's office, which made their A1C rise. This doesn't necessarily reflect that this patient has diabetes. So we're not going to look at the lab and we're not going to code. But pathology is more specific, and we're going to use that when it comes to neoplasms or cancers or tumors and things like that. So when it comes to diagnostic test results, we are not coding from those unless they are mammograms, because we know mammograms can reflect breast cancer, unless they are interventional cardiology. It's the only things we're coding from. We are not coding from labs and diagnostic tests. So appropriate medical coding verbiage. So again, we are only coding definitive diagnosis that we know this patient has. So if you're looking in a medical record and the provider says, patient likely has heart failure. They could not likely have heart failure. That doesn't tell us if this patient has heart failure or not. If you see the terms in a medical record, likely, symptoms of, pending, possible, probable, rule out, we cannot code from that because you're not telling me specifically if this patient has this condition. Acceptable verbiage, early signs of, evidence of, element of, significant for, the results show. So you know how we can't code, we cannot code from labs as coders, but the provider can say results show this. Because they could be looking at pathology. They could be looking at a mammogram. So results show, and whatever it shows, we code for that. So that's acceptable verbiage. So again, we have unacceptable or appropriate and acceptable or inappropriate and appropriate words or verbiage that we can use. Signs and symptoms. Again, coding guidelines instruct coders when it's appropriate to report signs and symptoms. Report codes for signs and symptoms when when the treating provider has not yet established a diagnosis or cause for those signs and symptoms. Your R category, and somebody just turn to the R category just to make sure I am correct. Your R category should be your signs and symptoms in your ICD-10 book. Correct or incorrect? Your R category.
Yes, signs and symptoms.
Okay, perfect. So this is where this section in your tabular list is where your signs and symptoms are located. Let me give an example where you would code these signs and symptoms. Okay, patient comes in to the doctor. 59-year-old white male comes into the doctor's office. They're coughing, sneezing, chills, fever. We're going to give them a COVID test. We're going to give them a flu test. We're going to rule out. That's what rule out means. We're ruling out what you have or don't have. So if they give this patient a COVID test, okay, COVID test comes back negative. They don't have COVID. Okay, flu test, results come back, oh, this patient does not have the flu. We don't know what this patient has. That's when we're going to code the signs and symptoms. We're going to code the fever. We're going to code for the chills. We're going to code for the sneezing, the coughing, because we don't know what it is. We do not have a definitive diagnosis, so we have to code the signs and symptoms. Same scenario. Patient comes in, coughing, sneezing, chills, fever. Give them a COVID test. It's positive. Give them the flu test. It's positive. We're going to use the code for COVID. That's U07.1. And we're going to use the code for flu. Don't code the flu often, so I don't know about the flu code. But we're going to code the flu. It's going to be in the A category because we know A is where those type of parasitic and infectious diseases are. So we're going to code for the flu, and we're going to code for COVID. When we have a diagnosis, we're not going to code for the fever, the chills, the coughing, and sneezing because we know why you have the fever. We know why you're coughing. We know why you're sneezing. We know why you have the chills because you have COVID. So we're just going to code the disease that you have. Overcoding is when you're trying, and it's going to be wrong. Overcoding is when you're going to code the chills, fever, coughing, sneezing, flu, COVID. You're overcoding because we know that patient has those signs and symptoms because they have this virus or because they have this condition or disease. Any questions about that? No. Okay. So these are just excerpts from the ICD-10 guidelines. And when you get to chapter 8, you can read that. We talked about coding clinic guidance. There's guidance there. Okay. So uncertain diagnosis. The coding guidelines to select an uncertain diagnosis codes differ depending on whether the service is outpatient or inpatient. So for an example, when we just talked about earlier, if there's a definitive diagnosis, we do not code signs and symptoms. That's in an outpatient setting. And make sure you write this down so you'll know it's going to be exam. In an inpatient setting, if they say likely this or we suspect this, we're going to code as if they have it in an inpatient setting. In an outpatient setting, we need to know for sure that this patient has this diagnosis. Inpatient setting, we're going to code everything that this provider says they likely have, probably have. We're ruling out this, everything except HIV and AIDS. We have to have definitive information to code for that. Have to have definitive information for that. Okay, any questions? No questions. Okay. So let's talk about COPD. This is going to be a diagnosis that when you start to work, not if, but when you start to work in this field, then you're going to see COPD a lot. Don't work at a pulmonary clinic or office or something like that remotely. You're going to see COPD all the time, main disease they treat. The Mayo Clinic is another resource I use for information. The Mayo Clinic is a great source of researching conditions and disease management information. You need to know anything about a condition, you need to know anything about disease, go to the mayoclinic.com. COPD is a chronic inflammatory lung disease that causes obstructed airflow from the lungs, mucus production, breathing difficulty, cough, and wheezing are symptoms. So symptoms of COPD: mucus production, breathing difficulty, coughing, and wheezing are signs of COPD. So let's go to our guidelines because I want to show you a few things with your guidelines for COPD. We know the guidelines are in the front of the book. So let's find our COPD guidelines. So if I get to the page first, I'll let you know what page. If you make it to the page first, let me know what page. COPD guideline, EFGHIJ. Okay, I need to keep going. You know how you have to say your alphabets out loud to make sure. HIJ. Okay, perfect. So in your ICD-10 book, if you have the 2024 version, then it's going to be on page G18 at the beginning of the book. G for your guidelines, page 18. So while we're waiting for, everybody to get to that page G18, how many of you all have learned so much about healthcare diseases and just everything that you thought you would learn since you entered this course?
Me.
Okay. So was a lot of this information that for everybody else, was a lot of this information things that you already knew? You might want to talk tonight.
Yeah.
Okay, so these were things, everything was things that you already knew. Nobody talk.
Some of it.
Okay.
Well, most of it.
Okay. You have your CPC.
Me?
Yeah, you sure.
Oh no, ma'am. I just work in
Oh, okay. So you know a lot of these things from your work experience. Okay.
Yes, and I don't have to have a certification. I still deal with coding.
Okay. And so you probably was just taking this class to advance your career to have the coding certification.
Yes.
There we go. Okay. So does everybody have G18 at the beginning of the book, chapter 10? So if you're having any questions, what code do I need to use? Am I using the right code? Your guidelines is where you're going to go. Your guidelines is where you're going to go to get this information. So I forgot, some of you guys already work in healthcare, so a lot of this information that you have, and it's advancement of your career. So, Chuck, because I know Fanta, you have your CPC already, right? And you're just coming to get your CRC.
Yes, ma'am.
Perfect. Okay, yeah. So chapter 10, diseases of the respiratory system, and it's letting you know that J00 through J99 is where your respiratory diseases are. And if you see on the outside, you see that U07.1, that's your COVID stuff. So they enter that and they put it in its own category. So chronic obstructive pulmonary disease, COPD, and asthma. So let me break it down to you like this, what COPD is. As you see here, COPD is a chronic obstructive pulmonary disease. So there's different types of COPD that you have. So COPD unspecified is going to be J44.9. So if we don't have a specification, then that's when we always use the unspecified code. Just like I50.9 is heart failure unspecified. If the documentation or the provider did not write that this person has left heart failure, right heart failure, acute heart failure, or whatever it is, acute on chronic, then we're just going to use an unspecified code because their provider did not specify in their documentation. So asthma, bronchitis, emphysema, these are types of COPD. But if the type of COPD is not listed, then we're going to use COPD unspecified. Any questions about that? Because a lot of people get confused with COPD. Asthma is COPD. It's just a specification of COPD. Emphysema, that's COPD. It's just specified as what kind of COPD, what kind of chronic obstruction that you have. Is that clear?
Yes.
Okay. COPD and asthma. If you're wondering, do I code these together? Do I not code these? Because this is going to be a question on the exam. Acute exacerbation. If you do not know, acute exacerbation is if it's happening now. You can have chronic asthma. For example, my son has asthma, but he's upstairs playing, he's fine. But if he was to have an asthma attack where he's breathing and he's wheezing and need his pump, that is what we call an acute exacerbation. So, acute exacerbation of COPD, bronchitis, and asthma. The codes in the category J44 and J45 distinguishes between uncomplicated cases and those in acute exacerbation. An acute exacerbation is a worsening or decompensation of a chronic condition. An acute exacerbation is not equivalent to an infection superimposed on a chronic condition, though an exacerbation may be triggered by the infection. So this is basically saying if you have a URI, upper respiratory infection, an acute exacerbation is not equivalent to an upper respiratory infection. It's not equivalent, although the upper respiratory infection might have triggered the acute exacerbation of your asthma. That's number one. Number two, acute respiratory failure. Acute respiratory failure is a principal diagnosis. A code from a subcategory J96.0. Acute respiratory failure or subcategory J96.2. Acute and chronic respiratory failure may be assigned as a principal diagnosis when it is the condition established when the condition established after study to be chiefly responsible for occasioning the admission to the hospital. This is another thing why most HCC jobs only want people with their CRC. So to look for things that are important. To look for things that could be inclusive of adding more revenue. So for example, if I'm working in an HCC position and I see that a person has respiratory failure, I'm going to ask that provider, is that patient on oxygen? So to add to the revenue or to make sure I have a complete picture of this patient's care or this patient's needs or their history. So respiratory failure to me, it equals that you're not breathing right. Your respiratory system has failed. So my question when I ask the provider, does this patient have oxygen? That's going to be my question for that for that provider. So number two, acute respiratory failure is secondary diagnosis. Respiratory failure may be listed as a second diagnosis if it occurs after admission. So let's say a patient is admitted to the hospital. And if they have respiratory failure after they're admitted, this is going to be the secondary diagnosis to whatever they was admitted for. That's going to be the principal diagnosis. Or if it was present on admission, but does not meet the definition of principal diagnosis. Okay. So these are the questions if you want to know, hey, do I code, do I need to code these together? Do I need to code that together? That is going to be your information from your guidelines to know that. So let's see. Okay. Again, COPD. When COPD is present, the patient is also at risk for heart disease, lung disease, and other chronic conditions. Providers manage COPD in many ways, and it's treatable. Not curable, but treatable. When COPD with asthma, this is going to be important. Write this down. This is going to be on the exam, and they want to see if you know. When COPD with asthma is documented, only use the code J44.9. COPD unspecified. You do not need to code the asthma separately. So they're gonna have. I guarantee you, it's going to be on the exam. When a patient has COPD and just asthma, so let me go to J44.909, and that should be asthma unspecified. J44.909. That should be asthma unspecified. So let's see. J44.909. That should be asthma unspecified. J44.909. Excuse me, not J44, J45. J45.909 should be asthma unspecified. There we go. J45.909 is unspecified asthma uncomplicated. So, when you get to things like, acute exacerbation, then you're going to have to add an additional code. But just asthma by itself, you're just going to code the COPD unspecified. Report J44.9, COPD unspecified, and J45.901, unspecified asthma with acute exacerbation. It's telling me you're having an asthma attack or it's worsening or it's cutting up on asthma. Adding this code displays a better picture. So if the person is having asthma with acute exacerbation, you're going to use both codes. Both codes. This is very important. Make sure you write this down. It's going to be on the exam. Guarantee you. For COPD with emphysema, you're going to use J43.9 as it is more specific than J44.9 COPD unspecified. So for a COPD with emphysema, if a patient has COPD with emphysema, then you're going to use J43.9. You're not going to use J44.9 because J44.9 is COPD unspecified. And if they have emphysema, then it's specified as a what kind of COPD that they have. Is that clear? Any questions about that? Or why we're adding this code or why we're not adding this code? Any questions?
No.
Perfect. Okay, so let me know if you need more time to write this down. Write down COPD and asthma, what code you're using. COPD and asthma with acute exacerbation. And COPD with emphysema. Let me know if you need more time to write that down. Anybody need more time? No? Okay. Malnutrition. Malnutrition is very important. It's an HCC code that adjusts and has a risk adjustment score. So sometimes providers may miss coding for malnutrition. So that's where you come in as the medical coder, and you're going to help this doctor's office, you're going to help this hospital, you're going to have to help this practice make sure they get their money up, and sort of say. You're going to help them make sure that they're getting the most reimbursement that they're supposed to have. So I can give an example because I had a doctor that I had to teach about this or whatever. So he would always miss the malnutrition code. But, and you know, the BMI is always going to be listed on the medical record. A person's BMI is going to be listed. And their vital signs, when you have their weight, their height, their temperature, their O2 status. When you have these things, it's also going to have BMI on the medical record because they have EMRs that automatically calculate the BMI according to the patient's height and weight. So if I see the BMI is under 16, if I'm looking at a medical record, oh, okay, patient's coming in, okay, they're treating their hypertension, their heart failure, they're doing this. That's why you have to pay attention to the entire medical record. So if I'm going through the medical record, blah, 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 oh, their BMI is a 14. They're severely malnourished. Let me send this provider a note. And I would say, because I can't tell them what to put, because at the end of the day, it's their say. But I can make these suggestions because they go to school to treat people. They go to school to diagnose. They don't go to school for coding. So they don't know much about how to get their money. They can't focus on making sure they get their money and focus on treating and diagnosing the patients. That's where we come in at. So I'll look and say, oh, the patient's BMI is 14. So I would send Dr. Smith a note. Hey, Dr. Smith, malnutrition is not added, and I see the patient's BMI is 14. Do you think or would you consider this patient to be malnourished? And they're going to come back and say, yes, this patient is malnourished. Okay, I am adding the code adding the code E, whatever for malnutrition. That's an HCC code. That's more money for their practice. That's more money for their hospital, for their company. Because I added the code, I'm looking and I'm seeing. That's why they like CRC, risk adjustment coders, for risk adjustment jobs. So also, and I'm not sure if I'm going to talk about this. No, I'm not going to talk about this in this lesson. However, if the BMI is 40 or above, I want you to write this down. If the BMI, because this is going to be on the exam too as far as inside of a medical case. If the patient has a BMI of 40 or above and they do not have any chronic conditions, that's going to be an HCC code. So if I'm thinking correctly, let's say their BMI is right at 40 to I think this 44 is the first increment. That code should be Z68.41. Let's look and see. Should be Z68.41. If I find it before you guys, I'll let you know, vice versa. Because I want to show you guys something too once we get to this code. It should be Z68.41. And this is going to be morbid obesity. 68.
It's on page 1328.
Just found it. So you see, if you go to the right of that code, Z68.41, don't you see that orange HCC in the box?
Yes.
So anything, if a patient does not have any chronic conditions and their BMI is 40 and above, you're going to make sure you capture their BMI when you're reading those cases on your exam. So if the patient has chronic conditions like hypertension, heart failure, diabetes, and their BMI is 35 and above, then you're going to code for morbid obesity. So when we're coding, we'll talk about this more next week in chapter 9. But when you're coding, if the patient's BMI is 41, that's over 40. So what you're going to do is you're going to use that BMI code Z68.41 to show their exact BMI. And then you're going to use the code, I think it's Z60, is it Z? No, E. I'm sorry, we're going to turn. We're going to go to E66.01. That should be morbid obesity. Let's go to E66.01. If you find it before me, let me know, vice versa. E66.01 should be morbid obesity. It's on page 552, and it is. So if a person is morbidly obese, you're going to code the E66.01 for morbid obesity, and you're going to code that Z68.41 code to show their exact BMI. So again, coding is about being as specific as possible when we're talking about this patient. So if you're telling me that this patient is morbid obese, okay, tell me they're morbid obese by showing the code, and then be more specific and tell me their BMI. If you do not add those two, the answer is incorrect. You have to add the morbid obesity code, and then you're going to have to be more specific and tell me what this patient's BMI is. Okay, and while we're there in the E's, turn to E40. I don't know why my mind just went to E40 the rapper when I said turn the code E40. Y'all listen to E40? Y'all know who E40 is?
Sure.
Yes.
Okay, I don't know. I thought about E40 when I said turn the code E40. I like E40. Okay, so this is where your malnutrition codes start, because if you see at the header, it says malnutrition E40 through E46. So let's start at E43. So you see where it says unspecified severe protein calorie malnutrition, starvation edema. So you see under there where it says starvation edema? I want to hear everybody say yes or no.
Yes.
Okay, perfect. Anybody else see where it says starvation edema? Okay, everybody saying yes. So if you're reading a medical chart and it says starvation edema, this is the same as unspecified severe calorie protein malnutrition. So you will use this E43 code. If a patient has moderate or mild malnutrition, you're going to use E44. Excuse me, if this patient has moderate malnutrition, you're going to use E44.0. If they have mild malnutrition, you're going to use E44.1. And if the patient has malnutrition and it's not specified as if it's severe, if it's malnutrition, if it's moderate malnutrition, I don't know. They just have malnutrition and the doctor didn't specify. You're going to use the code E46, unspecified protein calorie malnutrition. Unspecified malnutrition.
I have a question, Marciano.
Yes.
For the code E43 unspecified severe protein calorie, why is it saying severe and unspecified?
Because even though it's severe, is unspecified severe, there's different stages of severity. So if you look at E40, E41, E42, some of those are stages of severe malnutrition. If you look under number 1, Kwashiorkor, you see where underneath it says severe malnutrition with nutritional severe malnutrition.
Okay.
So was my explanation clear?
Yeah, so that means it's different severity of
Absolutely.
malnutrition.
You got it. There's different severities. And if I don't know the severity, well, I'll say if the provider does not specify the severity of their malnutrition, then I have to do unspecified severity because it wasn't documented the severity of it.
All right, thank you.
You're welcome. So you see here we have different BMIs. So when you're on your job and when you're on your exam, pay attention to the BMI. It's going to tell you if it's mild, moderate, things of that nature. If this is a normal BMI, if your BMI is 18.5 to 24.9, that's normal BMI. When you get to the BMI of 25, that becomes overweight. Then when it comes to 30, you're obese. Then when it gets to 35, 40, that's when you're morbidly obese. So when you get on your job specifically, if the provider did not document mild, moderate, or severe malnutrition, but you notice the BMI is in these ranges, then make sure you send a query. They're going to love you at your job. Make sure you send a severity. Make sure you send a query to say, hey, I noticed this. What about this? So acute respiratory distress. Acute respiratory failure. Well, I'll say this. I'll explain it this way. Acute respiratory distress and acute respiratory distress syndrome is not the same. So I'll explain that. Acute respiratory distress and acute respiratory distress syndrome is not the same. ARDS, which is acute respiratory distress syndrome, is a disorder that progresses fast and has symptoms of dyspnea, hypoxemia. So it has all these different symptoms. Okay, so most patients who develop this condition are usually already in the hospital, and ARDS is associated with sepsis and pneumonia. Respiratory distress, and I think this may be sum it up or explain it. Respiratory distress refers to having a difficult time breathing due to conditions such as asthma, pneumonia, or heart disease. So you're just in distress, or I say you're in distress if you're having a hard time breathing due to those conditions. But that does not mean that you have respiratory distress syndrome. So let's talk about, and we're almost done, let's talk about hemiparesis and hemiplegia. So we know hemi, it's kind of like one side, hemi, Hemi is one side. Paresis, kind of like paralyzed. Paresis and plegia is paralyzed. If you know someone who's a quadriplegic, then they can't move their arms and legs and things like that. So let's talk about this. Hemiparesis, hemiplegia is weakness on one side of the body. In the ICD-10-CM book, if the left side is affected, the default is non-dominant. If the right side is affected, the default is dominant. So most people in the whole entire world, most people are right-handed. We do have left-handed people. I have a brother who's left-handed. So we do have left-handed people. However, you see more people with who write or use their right hand more, who are right-handed, than you see people who are left-handed. So if a person has had a stroke or anything, and their left side is affected, we're going to say that that's their non-dominant side, unless the provider writes in the documentation, patient has had a stroke, they have hemiparesis on the left side, that's their dominant side, they're left-handed. So if the provider says that their left side is their dominant side, then we use that left side dominant code. If nothing says their left side in their medical record, if nothing says that their left side is their dominant side, then we automatically assume that their right side is dominant. Code for hemiparesis and hemiplegia if it is documented as weakness on one side of the body due to a stroke. And the other word for stroke is for cerebral vascular accident, CVA, or cerebral infarction. So diagnosis coding instructions. This is going to make sure that you are choosing the correct diagnosis code. Verify face-to-face encounter. And we know telehealth now these days, they're kind of dwindling it. But as of now, Verify face-to-face encounter. Make sure the provider is acceptable or approved. You know, we talk about RN, LPN, MA, CNA, all these things. Their notes do not count. They're not approved. So make sure the provider is acceptable or approved. The provider's signatures, and I would definitely write this down if I were you, all of this. Provider's signature must be present. Provider's printed name and credentials must be present. Doctor does not count. Dr. Smith on the medical record is nothing. No, it has to be Elaine Smith or MD. Elaine Smith, PT. Elaine Smith, OT. Doctor does not count. Date of service. The date of service must be listed on the medical record. If the date of service is not listed on the medical record, how do we know what date that this patient was, had their encounter? Documentation must support diagnosis codes applied. Check the assessment and plan for appropriate medical decision making. These are things to make sure that you are providing, you are coding correctly. HCC coding diagnosis. So, let me see. Boom, boom. Okay, so I'll just go over these things. When it comes to provider signatures that must be present, every encounter must have the provider's signature to authenticate the documentation is accurate. The provider's credentials must also be documented. Provider's printed name and credential. The legible it has to be legible. And it has to identify the provider, and it must be documented on the medical record. If the signature is illegible, the provider's name can be printed or used on the stationery that includes the name of one provider. Date of service has to be listed on the medical record. The codes cannot be reported for each face-to-face encounter. It has to have the date of service. The documentation must support the diagnosis. All diagnosis codes must be documented in the face-to-face encounter. The problem list alone would not support the diagnosis codes reported. Diagnosis codes may be reported by any portion of the documentation for the encounter. And of course, medical decision making has to be there. So, are there any questions? Any questions for tonight? Any questions as we wrap up? And I'm going to put this in the chat box, so we're going to do a few ICD-10 questions as we close out. But does anybody have any questions about tonight's lesson? Any questions? Okay. Does you guys, and tell me, do you feel like tonight's lesson was very clear for you guys?
Yes.
Okay.
Yes,
Okay. Does you guys feel like everything? Did these 12 weeks go back kind of fast to you guys? These weeks go back kind of fast?
Yeah.
Definitely.
Yes, it went by very, very, very fast. I can't believe next week is the final lesson. I can't believe it. I cannot believe it. Are you guys ready to become risk adjustment coders?
I know I am. Let me get more money.
Definitely.
I need a remote job. I'm tired of going that off.
Listen, I resigned from the job was paying $92,000 plus a bonus. They wanted me to start coming in, and I had to resign from the job because it just didn't work with this. First of all, I've been at home for years and years at this point. So going into the job, it's like, you're speaking a foreign language or something. And so, I like being able to go out, go to all of my son's programs, anything that he's participating in. So working remotely has spoiled me. And now for the right price, I will now. But working remotely has spoiled me to the point that I just would rather be at home. I can cook dinner during the day, take a little, when I take my break, instead of just walking to my car and break or sitting in the break room, I can start dinner. I can kind of put that on for the evening. Okay. So a patient is seen by, and I'm putting it in the chat box, a patient is seen by their family practitioner for confusion, depression, and behavior changes. Upon examination, the patient cannot remember recent events. The diagnosis, the patient, the provider, let's see, put this here. The provider diagnoses the patient with early onset Alzheimer's. And that is such a sad disease to watch. Does anybody know anybody that has Alzheimer's before? Alzheimer's. No. That is sad to watch.
have.
You have? Who said I have?
I have.
Yeah, that is so sad to watch.
She actually passed away not too long ago.
My condolences. That is so sad to watch. They can't remember. You know, it's frustrating. They don't know who you are. That is so sad. It's why we have to be so thankful and so grateful for a sound mind. We have to be so grateful, so thankful for a sound mind. And sometimes, like the simple things, you know, we take the simple things for granted. So I am putting this question in the chat box. So I want you guys to look up these codes and answer these. Okay. So what we're going to do too is, I'm in a generous mood. I think we can do this today. So remember, last time we gave away gift cards to the person who answered. Who wanted a gift? Cheryl, was that you, Cheryl, that wanted a gift card?
No.
Oh, I'm just going to give it to you. Who wanted a gift card? Tasia. Was that you, Tasia?
It was me.
Yes, that was Tasia that wanted a gift card. So what we're going to do today, whoever gets this correct first, then I have a gift card for you. So if you do get this correct first, so I just want you to email me and say, hey, I answered the question correctly first. This is the gift card that I like. So and then email me from the email, because it's going to be a digital gift card. So email me from the email that you want the gift card sent to. So here's the question. Did I do this to direct messages? I hope I did. Oh, hold up. I think somebody messaged me. Did I do it to direct message? Copy. Oh, no. It just didn't go through. Let's see. Here we go. Okay. So the question. A patient is seen by their family practitioner for confusion, depression, and behavior changes. Upon examination, the patient cannot remember recent events. The provider diagnoses, and this is the kind of question that's going to be examined. The patient diagnosis is the provider diagnosis is a patient with early onset Alzheimer's disease with dementia. What ICD-10 codes are reported? I'm gonna give you a chance to answer. So it's whoever puts it in the chat box first. So hello everybody on TikTok. I just wanted you to get a glimpse. Yes, Natasha, before I start, I see you. She said, yes, my grandmother's dealing with it and it's heartbreaking. It's very heartbreaking to have to care for or see someone that has dementia. So tonight, you see my office back there. I work from home. I cannot go anywhere other than my house. Like I said, I resigned from a job because they wanted me to go in. It's not on my list. So here's my office back there. This is where I work. You see all my monitors, computer set up. That's it. So tonight I wanted you guys to get a glimpse of the medical coding course. You see how I go through the course. I make sure everybody is comfortable with what we're going through. I'm making sure that everybody doesn't have any questions, because I do not like to move on to the next subject if people have questions. I'm responsible for making sure you guys have all the information you need to pass the exam. And I'm very, very much a stickler, because my success comes from not just collecting somebody money for the course, but my success comes from when they actually pass the exam. That's what makes me feel good. Not collecting money, not doing it makes me feel really good when I can assist someone in changing their life. I know what it has done for me to be a medical coder. I don't know about you guys, but I've lived paycheck to paycheck before. You know how some people say, yeah, I had to rob Peter to pay Paul. No. I had to rob Peter to pay Paul Nim. It was Paul and some more people with Paul. You know, so I've had the feeling of knowing what it feels like to live paycheck to paycheck. So when I'm able to help someone go from a job to having a career in a short period of time, then that's very fulfilling and very rewarding for me. For someone to say, hey, I passed the exam. You know, hey, I got my first job. That's very fulfilling and rewarding to me. Like my instructor, I have a very, very phenomenal person. Passed the exam in 2022, and she immediately, probably like a month and a half from passing the exam, she has secured 2 jobs, signed her offer letter, and she's only been coding for 2 years at this point, and she makes over $100,000. Now, that is not the expectation of everybody. My first coding jobs were $18 and $23 and 50 cents. So I've been coding for a while, maybe about 6-8 years or something. So my expectations and my salary, and I also have multiple coding certifications. So my salary is going to be different, or my expectations is going to be different from somebody walking in to this course. I should say the average expected salary for someone just completing a course, getting certified, is anywhere between $22 and $28. That's where the average range falls. It can be as low as $22, and it can be high as $28, sometimes $30. It just depends on the company and who it is. But you also have to think about this. Most jobs, we will have to work our way up to $22 or work our way up to $25. This is an industry that you can come in making great money, come in making $50,000 on your first job. The reason we as coders get paid so much money is we're responsible for reporting these diagnoses, and we're responsible for these providers who see these patients. We're responsible for them getting their money. So if we're responsible for them getting their money, how are you going to give me some little money? Then the math wouldn't be mathing. So that's why coders get paid a great amount of money, because it has the responsibility that is great. A lot of people, they think, oh, if I want to do healthcare, I want to do an RN. RN, LPN, that is great. If you want to do nursing, that is great. Well, for me, my goal was to be in healthcare and to figure out a way to make just as much money as nursing or more and not do anything clinical. I've been on projects where I would pay anywhere between $45 to $77 an hour, and I'm doing revenue cycle, I'm doing coding, I'm doing provider education. I've made over $100,000 before, or whatever, just in different projects or doing certain things. And so a lot of times when you're in nursing, you have to work overtime and really bust your tail to do that. So this is just a lucrative field as well. So the CRC course is Certified Risk Adjustment Coder. It deals with chronic conditions only. The class is 12 weeks. That's 3 months. 3 months. That's 12 weeks out of your time to better yourself, to find a career, not just a job. And you can build on that and, just constantly have your salary going up and up. So the reason why the CRC is very important to coding in this industry, because it deals with chronic conditions, as we know, you can just look around you. As we know, the population is getting sicker, older, or both. So they need someone to specifically know how to code for these conditions, and someone specifically to know how to make sure that this practice or this hospital is getting the reimbursement that they're supposed to have. So let me go through the questions. Give me just a minute. I'm going to put you back up right here, and I'm going to answer all the questions. So let's see who won this gift card. Okay, let's see the answers in the chat box. Let's see who get the first answer. Okay. So let's see who won the gift card. Who wants to share the gift card with me? So Fanta had D. She had it first. 2 minutes later, Miss Cheryl, Crystal, D, and someone said E. None of the above. So the answer is D as in Delta, D as in dog. So let's go. Let's read it, and then we're going to make sure that everyone knows how we got this answer. And I'm sorry for everyone who was not done yet, but let's go ahead and go over the answer. So let me read the question again. Same kind of question that you would see on the exam. A patient is seen by their family practitioner for confusion, depression, and behavior changes. Upon examination, the patient cannot remember recent events. The provider diagnoses the patient with early onset Alzheimer's disease with dementia. What ICD-10 codes are reported? So first, let's go to G as in girl, G30. Let's go to G30. G30. G30.0 to be exact. G30.0 is going to be on page 602. So G30.0 is Alzheimer's disease with early onset. This is Alzheimer's disease with early onset. So you see, we have different options. And again, Coding is about choosing the option to the highest level of specificity. Highest level of specificity. I can say that's a man, or I can say that's a 62-year-old man. I can say that's an Asian 62-year-old man or a 62-year-old Asian man. I can be as specific as possible when I'm describing something, and this is what we have to do with these codes and these conditions, if it's available in the documentation. So G30.0, it says Alzheimer's disease with early onset, and if we look at the question, it has early onset. Now let's go to the top, to G30, the top of the category, where it tells us what's to follow. So you see where it says G30 and it just has Alzheimer's disease? Look at this. This includes Alzheimer's dementia, senile and present now forms. So this already tells us that this includes dementia. The question also said that this patient was diagnosed with Alzheimer's disease with dementia. So we know that this G30 category is going to cover that. Look at the red instructional notes. I can't stress this enough. When you're on your exam, the red instructional notes is your Bible for coding. You have to look at that to make sure that you're selecting the appropriate code. So let's go through the red instructional notes for the G30 category. It says, use additional code, if applicable, to identify delirium, dementia with anxiety, dementia with behavioral disturbance, dementia with mood disturbance, dementia with psychotic disturbance, dementia without behavior disturbance, mild neurocognitive disorder due to known physiological conditions. So the answer was F02.81 inclusive of G30.0. So let's look at F02.81. Let's go to the code F02.81. It's on page 562. The definition is dementia and other diseases classified elsewhere. And we know that this is dementia and another disease because this is Alzheimer's with dementia. So we know that this dementia is inside of another disease that's classified elsewhere, and it's classified on another page. It's classified in another category. So F02.81 reads, dementia and other diseases classified elsewhere. Unspecified severity, because it doesn't tell us the severity, with behavior disturbances. With behavior and disturbances. So this is going to be the correct answer. They have confusion, depression, and behavioral changes. So again, when you're on this exam, answer exactly what they're asking. So we know from earlier, let me see where you guys listening. The R category is for what? What's the R category for? What's the R category in our ICD-10 book for? What is signs and symptoms? So we see that some of these signs and symptoms are confusion, depression, and behavior changes. But remember, the provider diagnosed this patient with early onset Alzheimer's disease with dementia. So remember, we are not going to code the signs and symptoms when we know what the diagnosis is. That's because the confusion, the depression, the behavior changes are all because of the Alzheimer's dementia, because of the Alzheimer's dementia, the early onset. Is this clear, or somebody want me to explain more? You know I explain more if you ask me to explain more. So Keisha, with you putting E, none of the above, do you see how we got to this answer?
Yeah, I was going to put that, but I just seen that 6-digit, that it required a 6-digit on that.
Okay. Now, again, nobody in this class have their CRC but me. Nobody on this call does not have their certified risk adjustment coding certification but me. So nobody on this call can say, oh, she asked that. Not just you, just anybody. Oh, she should know. Nobody, because if everybody's here for the same goal, Because if each one of you guys, if y'all already knew what to do to get your CRC, you wouldn't be in this class every Wednesday for the last 12 weeks. So if you need me to go in detail, anybody, it's never a problem. I would probably feel some type of way more if you don't ask me a question, because my goal is to answer all of the questions so you can have the most clarification so you can pass this exam. So Keisha, would you like for me to explain in further detail, or do you feel like I explained it enough for you to understand it?
You explained it.
Perfect. Okay. So again, we talked about this in a prior lesson, probably about 8 slides up. If we have a definitive diagnosis, we are not going to code the signs and symptoms. So we know that the confusion, the depression, and the behavior changes are because the Alzheimer's disease, the early onset with dementia. That's why they're confused. That's why they're depressed. That's why their behavior has changed, because they have Alzheimer's with dementia. So if we're using process of elimination, we already know that the R code or the R categories, those are our signs and symptoms. But we have a definitive diagnosis of why this patient is confused, why they're depressed, why they have behavior changes. So you could have automatically looked at A, B, C, and D and said these are not it, because they are coding for these signs and symptoms when they already have told me that it's because of Alzheimer's dementia, early onset of Alzheimer's with dementia. Any other questions? Okay.
Nope.
Okay. So I'm glad everybody was able to join. I forgot who told me they weren't going to be able to join today, but it's okay. A few people weren't able to join. I'm glad you guys were able to join. You guys have stuck it out. Everybody on this call has been here throughout the 12 weeks continuously. I already knew he was coming. You hearing me wrapping it up. It's like a cue. Like when I say certain words, I hear them feet pitter-paddling here to do his thing at the end of the class. But, and it's crazy because, how you know I'm wrapping it up? You only supposed to be listening to me, Okay, so listen. Everybody here has worked hard. They have been continuous with coming to class. Make sure you complete all of these modules. Again, after the class ends, you still have access to the modules for up to a year. When you get your exam vouchers, you have up to that doesn't mean take a year, but you have up to a year to take this exam. My suggestion is to take the exam as soon as possible so it can still be fresh on your mind. Take the exam soon as possible so it can be fresh on your mind. Don't wait a year to schedule your exam. Don't wait a year to finish this course. Again, you have up to a year in these modules before they disappear. So it's not like once the class ends, once it's over with, it's not like when the class ends, when it's over with, then you have you don't have access or anything. You can go back and you can review. Even after the class ends, I am here. Is everybody in the Allied Health Prep Academy group? Everybody here is in the group?
Not me.
No, okay.
Yes, I am.
Okay, so let me put you in the group. The group has, and this is the group that's only inclusive of all of the students who has ever taken this class. And maybe about 300 people or something in the class, because everybody doesn't have a Facebook, of course. But this group is comprised of old students, new students. If you guys get in, or whoever else is in this class who is in, get down. Of everybody else is in this class who's in here. So they tend to lend help to those who are going through the class now. The group of people is people who already have their RC from taking the class and passing it, who's still working on their CRC. So it's a wealth of information in that group, a wealth of information. So get in that group, send me an email and say, hey, Marciana, I'm not in the Allied Health Prep Academy group. Again, all of the people in this group are people who have taken this class only. So they can speak to whatever, hey, chapter 4 was this, or chapter 5. Everybody in their group has taken this class only. So send me an email to say, hey, Marciana, I am not in the group. And I'm going to reply to that email with the group's link so you can get into the group. If your name is something different on Facebook than you signed up with for this course, let me know that my name is Mary Blue-Eyed from the South Side Smith. Let me know that that's you, because I wouldn't know that that's you. So send me an email and let me know that, hey, I'm not a part of the group. I'm trying to get in the group. And what are any questions? After this class ends, get in that group. If you have questions, it's okay to say, hey, I'm reviewing, I'm studying for my exam, and this is something that I don't quite understand. That's why I created that group, so there can be access to information even after the class is over. My goal is for everybody to pass this exam, so I want to do everything in my power to make sure that I've given you everything you need. I've given you all the tools, and even after the class, you still have access to me and other people to be able to get the information that you need. So any questions that we have? Any questions before we end? Okay, perfect. So I know sometimes class runs to 10 o'clock. You know, it's usually over with an hour and a half. However, I would rather give you more information than shortchange you and give you less. So if that's all, I will see you guys on next week for the final class. And then after the week after that, we'll do our review of the complete course. And then we'll do the writing in our books for the exam.
Okay. Thank you very much.
You're welcome. There you go, Ivy.
Bye, everybody.
Bye. Good night.
And bye to the TikTokers that's over there.
Bye, Ivan.
Bye.
Y'all have a good night.
Bye.
Y'all say
Bye.
Wait. You can tell her to log into mine.
Yeah. I'm almost like to finish my TikTok. Tell TikTok hi for you, so I can finish.
Hello.
Okay, now bye. Go put your robe on. You're supposed to be asleep. I don't know why you be trying to stay up on the nights I have class like I ain't paying attention. I see you. Move.
I know her. She ain't good. Ow.
Well, move. Okay, so let me get a chance to answer the questions. For your CRC class, yes, it's just the ICD-10 book. So let me go back. So, of course, I've been on here 2 hours, and I really appreciate all you guys joining me. So if someone has questions, I want to make sure I answer all of those questions. Again, the next course is going to be January the 15th through like April the 16th. I have to get the exact dates. Registration starts November 15th. That's when you're able to register for the course. The course is $1,250. If you pay it right out with your credit card, your debit card, or whatever the case, it's $1,250 right out. Or we have a payment plan. Excuse me, I've been talking for so long. We have a payment plan, $450 a month for 3 months. How the payment plan works. To register for the course, you will pay your $450 down. That same card that you paid with, that next month, on the same date, it's going to try to deduct from your account. It's going to try to deduct from your account from that day for the next 2 weeks if it's not in there. After that, it automatically unenrolls you in the course. And you would have to pay to get back in the course. And it'll be, of course, at my discretion if you didn't let me know, hey, the payment might not come out, whatever the case. So it'll be, and it's notated, it'll be at my discretion if you're able to come back in the course. And typically you are, because I understand sometimes stuff happens. So the initial course, which includes the course material and weekly tutoring like we just did tonight, $1,250. If you get on the payment plan, it's $450 for 3 months. That's why I typically start the registration months before the class start. That gives people to pay for November, December, and January. By the time class starts, they've already had their payments out of the way, so they won't have to worry about that going forward. So the next option is $2,250. What that includes is your course material, of course, weekly tutoring. It includes the exam because improved instructors and stuff get, discounts on exams or whatever. The exam's like $500. And a lot of people say, whoa, $500 for an exam? But this is such a lucrative career that once you get everything, your ducks in a row, and you find this coding job, $500 is going to mean nothing to you. Trust me. I told you I was robbing Peter to pay Paul. Trust me. So the $2,250 includes the course material, weekly instruction, your exam, your book, and your AAPC membership. So AAPC is the American Academy of Professional Coders. That's who's going to certify you as a medical coder. So you have to be a member of the organization in order to sit for the exam. So again, if someone is in billing and coding school, which is two different things, so be careful, watch out for that. They just want your money. They won't tell you is a difference between billing and coding. So if you're looking for billing and coding schools, billing and coding jobs, or what they're looking for coding, understand there are two organizations that are reputable that employers are looking for. So if you want to sign up, even if you don't come through my course, if you're signing up for a course and you're going to pay about $12,000 to $20,000 if you go to a trade school. So if you're signing up for a course and say, hey, sign up for a medical billing and coding program, ask them one question. Does this course or does this program prepare me for a certification through the AAPC or a certification through AHIMA, AHIMA? And if the answer is no, that's not the program for you. Employers are only looking from AAPC and AHIMA when you have these certifications. So $2,250 includes everything, your exam, your book, your membership, and the $1,250 includes weekly instruction, and it also includes your course material. There is also a group. Everybody who has ever paid to be in this course, they have the option of joining the Facebook group. There are videos in the Facebook group. It's not, my computer's charged. But there is former students in the Facebook group, people who have their CRC already. Some people are still working on it, things like that. Some people had to stop, whatever the case. But it's a group full of people that has taken this course, so they know everything that you're going through, everything you've read, everything that you're trying to do. So you can ask questions to them. You can ask questions to me. I do live sessions in the group. Next week, I'm planning to do a live session for resume assistance for everybody who's taking this class. So it's more than just assisting you with getting your certification. We talk about life skills. We talk about job skills, interview skills, resume skills, things of that nature. So again, the class is 12 weeks. And so your expectations can be to enter the class, take the class for 12 weeks, take a little time to study, go sit for your exam. Once you pass the exam, you will be a certified risk adjustment coder. And again, the average pay is anywhere between $22 and $28. So let me answer any questions. Okay, so how much is it? I just told you guys. So also, I want to let you know, I only accept 60 students. That's my number that I feel comfortable with. I've had more in the class and I found that was not conducive. So now I only limit it to 60 people. So if, when registration comes and you find yourself cannot register, if you're interested in a class, it's probably because it's full. Sometimes it gets full, sometimes it doesn't. But I only accept 60 students because, as you see, and if you've been on this live, I thoroughly go through a lot of things. And it can't be more than 60 people and be a productive class because there will be too many. So let's see. Any other questions? I probably answered everything. Let's see. Z93. The trach is incidental to the encounter. This is the reason for the encounter. So someone says Z93, the trach is incidental to the encounter. The trach is not incidental to the encounter. Somebody wrote this. So those are two different things. And that's why it's two different codes. A person can go in for hypertension and the trach may not even be, need to be touched. The trach is fine. They're coming in for their blood pressure. So we will use one code. It's not incidental to where you have to use both if you use one. So Z43, that's why it specifically says the encounter is for attention to the trach. And that's why Z93 says trach status. It just shows the status of the trach. Z43 says in attention to. This is your encounter. You're coming in for the trach. So it's not the Z93, which is the attention to. No, Z93, the status, is not incidental to Z43. And if it is, now I'm not above learning. I'm not above growing. But you'll have to show me in the guidelines, and you'll have to show me CMS. You'll have to show me in black and white. Because I'm not above learning. I don't know everything. When you're above learning or you feel like you cannot learn anymore, then you've hit your peak. Find my charger for me, baby. So you've hit your peak if you feel like you can't grow. Or if you, if you feel like you can't learn. So it may be true, but show it so I can know going forward that is the correct answer. A1C is over time, like 3 or 4 months. So you mean blood sugar? Absolutely, your blood sugar. Absolutely. Thank you for correcting me. Thank you so much. Somebody said I'm doing it. That's the same person that told me that it's incidental too. I really want you to get with me and say, if it's incidental too, please let me know. Again, I am not above learning. I am not above growing. I do not know everything about coding. I know a lot and I know how to do my job well, but do I know every single thing about coding? Absolutely. So if someone is coming to tell me something about coding, please don't let me be out here in the dark. Let me tell you something. Boy, ain't nobody following you. Come here, please follow him. These grown people. Grown people don't need to follow you.
Please follow.
Oh, okay, we can show this. Oh, that's nice of you. Please follow my mom, please. Oh, give me a kiss. I thought you were talking about them follow you. They're grown. You don't have to go upstairs. Okay. So, again, thank you. Thank you so much for the gift. Thank you. Look, this is my first gift. I've been on here working hard, doing lives, and I don't know if I got to do a handstand or get to do some cartwheels.
That's his second gift.
It is? Okay, that was my first one.
No, it's his second one because while you were still on the meeting, I saw somebody put a rose.
Oh, okay. Okay. So thank you so much. Again, Miss Millie, stop. 333. Again, if it's incidental too, please get with me. Please get with me and let me know and show me it's incidental too, because I still like learning. I'm not above learning. I'm not above growing or anything of that nature. So if I am wrong or if I need some additional information, plug me in. So you're doing an outstanding job. Keep going. Thank you so much. I definitely want you to get with me. Thank you for this. You are welcome. Like I'm telling you, and I'm not just saying this, I have the spirit of I want to help other people. When you've been through certain things, now again, everybody can't go with you and you can't take everybody on your journey and you can't help everybody. Sometimes you'll lend that rope or that life jacket for somebody to help them and they'll make you drown. But those who really want that help, that's what I'm here for. Somebody took their time to introduce me to coding. Somebody took their time to teach me. And it has tremendously, all this stuff, it has tremendously changed my life. So I like to pay it forward and do that for those as well. So someone said, thank you for the information. My coding class starts 11/1. I'm so excited. Congratulations, Tracy. Congratulations. Make sure. Now, sometimes a lot of people study for the CBCS through Penn. If you go to Penn Foster, and the CBCS is Certified Billing and Coding Specialist. I am not saying that you cannot find a job with that CBCS, that certification from Penn Foster. I'm not saying that. What I'm saying is, if you're looking for that money in coding that hits, you have to get a certification through the AAPC or AHIMA. Congratulations, Tracy. Congratulations. And I'm wishing you all the best on your journey. Ask them what certifications that you are preparing for so you can be sure. Congratulations. So someone says, currently in school and going through medical terminology and anatomy and physiology class. Yes. So I also teach medical terminology, anatomy, and physiology when you are inside of my coding course. So a lot of times people say, oh, I need to take medical terminology first. I need to take A&P first, and then I'll take your class. No, I understand that that's a very important or imperative part to learning how to code is knowing medical terms, recognizing medical terminology, and also A&P. So this comes along with it. See? She said she's going to be praying her way through. Tracy, whoever you are, Tracy, you got this, honey. You got it. You got it. You got this, Tracy. Someone said they've been looking for me. Here I go, like Mystical. Here I go. You've been looking for me. Here I go. Okay, so somebody said they was looking for me. Okay. I'm just making sure I'm answering. Somebody said coding is not hard. I think nothing is hard if you put your time and your effort and energy to it. We would think performing surgery is hard. But if we talk to a surgeon, they do it every day. It's, oh, it's not hard. I do this with my eyes closed. So I feel like nothing is hard if you put your all into it and you use your effort. Yep, and so I talked about working remotely. So I resigned from a high-paying job, and it's because like they wanted me to start coming in 3 days a week, and I've been so adjusted to being at home that wouldn't just work. And I know with this coding field, if I got that high-paying job, then I would definitely get another one. It's like too many coding jobs out here for me to, not to get exactly what I want out of a job. Now, of course, starting out, if you want me to be there 9 days a week and it ain't but 7, I'm there 9 days a week. So I can get my foot in this door and learn. But now that I'm established and I know a lot of things, I kind of can pick and choose. So Miss Lola said, and she's been having some good comments too. Thank you, Lola. Lola said, yes, indeed, plus kids sick that can stay at home with you. That's one of the things too. I have 2 children. Well, I don't know if the other one's considered a child. He's still my child. He will graduate in December with a degree in physical therapy. Yay, mom. Yay, dad. Yay, me. Yay, son. So he also has to go about 4 more years, after then. But he will graduate with his bachelor's of science in December. So I'm excited about that. So I don't have to worry about him. He's gone. He's grown. He's out of my hair. He's in school. So I also have a 7-year-old. And so, sometimes kids get sick because other kids bring germs to school, or he might just catch a cold or be sick or got a fever or whatever. So I don't have to say, hey, I need to take some PTO today or call my job. Hey, I know this is the 3rd day. Please don't fire me, y'all. Please don't. My son is sick. I need to stay at home. No, he can just get upstairs or get on his couch and I can check on him, and I can be at my computer back here and I can go to the couch and I can check on him, and I can, go upstairs in his room, check on him. So I don't have to take PTO. That's why I just like being at home. So someone says, I'm interested in taking your course. Do you have learning for medical terminology included? Yes, I do. How long is the course? 12 weeks. Do you teach various specialties? So I used to teach the CPC, but my little pocket that I love, because the class is so short and I can just help you in a short period of time, do your thing. I like to teach the CRC. So I teach the CRC. When can you apply for the course to start? The link is in my bio, and 11/15 is when the course is going to be started. Oh, I can invite somebody to join live. Okay, to join live as a guest. Oh, I can just invite you. These are not people that requested. Okay. Can you please explain your CPC total package? When does the next course start? I am not teaching the CPC next year. The CPC, the course itself takes about 16 to 20 weeks to teach. That's almost half the year. I love to train. I love to teach. So I can have about 4 classes of the CRC, whereas I can only have 2 for the CPC. And it's a lot, because although I have other instructors, I still like to be hands-on to deliver my information, because people are typically signing up because they hear me teach or they know me. So it's hard to navigate between the both. So I saw somebody say, oh, I just completed my CPC. How much is your course? My CRC course is $12.50. Congratulations on completing your CPC. Congratulations. That test is a booger bear. So for your CRC class, is it just the ICD-10 book? Yes. Typically with coding, you're going to need 3, like the CPC. You're going to need 3 different coding books: your ICD-10 book, your procedure book, your supply and DME book. Well, with the CRC, you're only coding from 1 book. That's why it's my favorite. You're not flipping through 3 and 4 books. So let's see. I like this. Who is this? Kat J. I love this. She got her CPC, her CPMA, her CRC, her CPCD. Oh, she got all them credentials behind her name. Whoever this Kat J is, congratulations, Kat J. I love that. She got all these credentials. Kat J, baby. Don't play with Kat J. She got the CPC, CPMA. CPMA is Certified Professional Medical Auditor. They're going to audit records. Come on, dude. Kat J, don't play with her. It's easier than Kat J. I wonder, can I get you on the live? Is she still here? Oh, she's still in here, Kat J. How do I invite you to come on the live with me? Do I invite? Oh, an invitation sent. I think I just sent you an invitation. Come on, get on this live, Kat J. I know it's late and you probably in the bed. So you don't have to show your face. Will you get on this live with me, Kat J? I ask of thee. Let me see, what's this? No, I don't want to unfollow. What is this? Oh no, Cat J. Oh, is this Cat J? Don't play with her. This is a.
Can you hear me?
Yes.
Hi, how are
Oh,
you?
stop.
Nice to meet you.
Hey, how are you? Look, I've never had anybody join the live. Thank you so much. So can I listen, don't play with you in the alphabet soup. Don't play with you, Miss Cat J. So listen, will you tell everybody just a little bit about your coding journey, how you got into coding? Like, don't play with you with the CPMA. Don't play with you, Cat. Don't play with you.
Yeah, I don't mind telling. So
Thank you.
I started just because I wanted to be in the medical field, and I just kind of lucked up on it, and it's always been like I hear that a lot. Like people don't know about medical coding and they happen to look up on it. I was looking for a job that made as much as nurses, but not being patient, patient forward, having to deal directly with people. And I went into the administrative side and I saw coding, and I kind of got into claims adjudication first. I kind of worked my way up from there. Like first I was just approving claims, and then I ended up applying for a billing job, ended up getting the billing job. Didn't really know that I was applying for a billing job. I just needed something in the claims department. And while I was doing follow-up for billing, I noticed that I had to do a lot of appeals, and by me having to do appeals, I needed the code book in order to kind of make my appeal strong, to submit to the insurance companies. And my supervisor at the time, she was like, "You always picking up that code book. Is that something you're interested in?" And I was like, "Yeah," and she was like, "You should look into it. I think it'd be really good." So I did some research on it, came up upon AAPC. I took my tax return, paid for my class, and
Don't play. I did the same thing. Don't play with you.
From there, that was it. It was on. And like my supervisor at the time, she actually vouched for me. Like she went over to the coding department. She talked to the supervisor over there. She let them know that I was studying for my CPC, and if they had any openings, that I would be a good candidate for it. And when job came up, she the one that actually emailed me the job and was like, "Did you see the opening? They finally got an opening. You need to apply." I applied for it. She kind of walked me through, gave me advice, like something you was talking about, resume advice. She told me, make sure you write a cover letter. Make sure you email them and follow up and just tell them thank you for the opportunity. Make sure you keep your name top of mind with them, so that they can know that you're really serious about this. And she was like, "I'll do whatever I have to do to support you." But I ended up going in there before I was even certified. Interviewed.
Yes, before I love it.
Yeah, they gave me the job, and they told me I had a year to get my certification, and that was all she wrote. That was my son's 18. That was like 18 years ago now. So yeah.
Oh wow! See, I love it.
It's been a great job.
So you got your CPC like that long? You've been coding for like 18 years?
Yeah, I've been coding. Well, I did billing for 3 of those 18 years, but yeah.
I love it. I love it. I love it.
So now I have my own billing business. So like I still code, like I still have a job, 9 to 5, but I have a billing business, and I code for private practice. I mean, I bill for private practice providers. So when you was on here just talking about the money that you can make, it's like the sky's the limit. You take this career where you want to take it. That's what I love about coding, is you can create your path. So
absolutely, I love it. Would you drop your email in my messages? I love to connect with people who have more experience than me. Sometimes people can be intimidated. Oh, she know more than me, or she's been doing this more than me, more than me. But iron sharpens iron, and I love to connect with people who have more experience than me. They probably know more than me. They probably can give me insight that I had not thought about. And since you do stuff privately, yeah, definitely send me your information, because I got some information to share with you as well. So make sure you, if you get a chance, to send me your email address or whatever contact you want to send me. So thank you so much for joining.
Oh, you're welcome. Thanks for inviting me up there.
That's amazing to hear that you've been coding this long, and you've been in this industry, and it has been nothing but up and up and up for you. So thank you so much for joining. Thank you so much for the gifts. And I wanted to give somebody else, I wanted to let them hear somebody else's perspective, because, I make it sound glamorous, because it is to me now. I've went through the hard part, and it's smooth because I know what I'm doing now. And just as you, and I tell people, and it seems like, we hear like Martin said, I tell people, don't let things discourage you. People tell you ain't no jobs in coding, or people tell you you gotta be certified. Just as you, I got my first coding job before I was certified, and they gave me time to get certified. So if you just get in that right pocket, you can find opportunities without having that paperwork. Sometimes your
Absolutely.
mouthpiece and sometimes people vouching for you can get you in rooms that you don't even think you can be in.
Yes,
So
my whole spiel to people that's new into the industry is networking. I got every single job that I've landed just because of networking. Because me network going out there, going to my AAPC meetings, connecting with different departments in the hospital or health system that I'm working with, even with my billing business. Like every provider that I'm billing for now is because someone referred me to them or them to me. So our industry is really big on networking, and that can be intimidating because some of us are introverted. I'm very introverted, but when it's about my money, I'm gonna go out there and do what I
right,
gotta do.
right.
They go out the door. But networking is what gets you in the door, because you have to let people know that you out there, you available, and people will take a chance on you if you just network.
Absolutely. What
Yeah.
AAPC chapter do you belong to?
Omaha, I'm in Nebraska.
Oh Lord. Okay, Nebraska. I've never even known anybody to live in Nebraska. Do people
Yep.
live there? People live in
Yes.
Nebraska? Okay. Okay, so I never even known. So I'm the in the AAPC chapter, and actually for the 2022 year, I was
Mhm.
actually the president of
Oh,
the
nice.
AAPC chapter here in Atlanta. So
Okay.
yes, we need to
That's nice. Yeah, I'm the
send me your
education. I'm
information
the
so we can
education
connect.
officer for our local chapter. So
Okay.
yeah, yeah, that's cool. Okay, yeah.
Absolutely. Thank you. Thank you so much for joining me, Miss Kat.
You're
And
welcome.
please send me your information as I wrap up this live. But please, I got some information for you.
Okay, I sure will. Thanks.
Okay. Thank you so much for joining me.
You're welcome. Have a good night.
Bye.
Bye.
That was so dope to have her join. So, I've always, I talk about it and I make it seem like this. This is somebody who's been doing this longer than me. So I ain't invent the wheel or anything. I just get on here and do my thing and whatever. But this is somebody who's been doing this for 18 years. So if she's been doing this for 18 years, it has to be some greatness to it. Or people will be like, I don't know, I've been doing this too long. Let me find something else. No, she's been doing this 18 years. That tells you all you should know. So someone said, if my school is training me for a CBCS and CBCA exam, do I also need additional training for the CRC? Absolutely. The CRC is totally different from the CPC. As you guys were listening to my call when I was training my students, some of my students on this call have the CPC. You're not going to learn the same thing in your CPC class as you would in CRC. That's why CRC only has one book. It's a different focus. So yes, you're training for your CBCS. Congratulations for getting your CBCS. I'm congratulating you in advance because you're gonna get it. And also with that CBCS, trust me, I ain't gonna tell you nothing that I would no advice I wouldn't take for myself. So yes, get your CPC as well. The A is going to come along with it because the A just let them know that you're an apprentice, that you're new to coding. And like the CRC, that's another reason I like to teach it as well, because the CRC does not come with the A on it. Some jobs will kind of be leery hiring people with A, but you can definitely find a great job with your CPCA. And after so long, that A falls off and you just have your CPC. Congratulations. I can't say it enough. I wish I can jump up and do a toe touch or something for you. But congratulations in advance on getting your CBCS and your CPC. Congratulations. Okay, someone said, how can I apply for your CRC course? November the 15th is when registration starts. I usually start registration exactly 3 months prior to the class. The class is going to start January through April. Let me see. Yeah, I think it's January 16th, middle of January to April 16th. So that's when it's going to be. I think I got to look again. Got to make sure. But yeah, I think it's, let's see, yeah. So it's January through April. And then I'll get back on here when registration starts. And then I'll let you know that registration has opened. So I'll let you know registration has opened. So you'll be able to apply. Oh man, I hate I missed this live. Hey, baby, we've been on live 2 hours. 8, 9, 10. We've been on live almost 2.5 hours. So before I go, does anybody want to join? Does anybody have any questions or anything? Anybody want to join the live? Thank you so much. Would you recommend a CRC first or CPC? If you're already in school for your CBCS, make sure you complete that first. I always recommend that people complete what they started first before going on to something next. We can get easily distracted. So get your CBCS, study that, get your CBCS. And after your CBCS, then you can come back, take your CRC, and then you can take your CPC. I recommend the CRC first because you're only using one book. It's a shorter period of time, and you can get out here quick and go and get certified. And then you can come back to the harder thing or the most challenging thing, which is the CPC. So if you want to know more information about the CPC, Elashivia, I don't want to chop your name up because my name long and difficult to pronounce sometimes. So look on my YouTube channel. My YouTube channel is MJ the Coding Coach. MJ the Coding Coach. Everybody in this live right now, go and subscribe. MJ the Coding Coach. That's going to give you all of the coding information you need to know. It's going to tell you what's on each exam for the coding certifications that I teach. It's going to tell you how challenging. It's going to tell you what's on it. It's going to tell you just my experience. It's going to show you students who have passed this exam and things like that. So I am MJ the Coding Coach on YouTube. And I'm Marciana Claybrook Jones on Facebook if you want to follow me on Facebook. So Facebook is Marciana Claybrook Jones and YouTube is MJ the Coding Coach. Now the Facebook, you don't have to follow me. I put coding jobs information sometimes, but the YouTube, get on their YouTube, MJ the Coding Coach, all of the coding stuff that you would need to know to make your decision if you feel like this is right for you. I'm interested in it. Let me get some more information. The YouTube is where it's at. So I am going to answer these last questions, and I'm going to get out of here. I just completed my CPC. How much is your course? It's $12.50 just for the weekly tutoring and the material. And if you want to include your exam, your book, your organization membership, that's going to be $22.50. Also, to let you know, I accept Klarna, Afterpay, and Affirm. Klarna, Afterpay, and Affirm. I do accept those. So you can definitely, if you don't have the money to actually do it, Klarna, Afterpay, and Affirm is accepted. Klarna, Afterpay, and Affirm. And follow me on YouTube, MJ the Coding Coach, all your coding information. So thank you so much, you guys, for joining me for this 99-hour live. But I wanted you to get a glimpse of how my actual class goes, because sometimes you might have had something different in your mind. So I wanted to show you how my class goes, how I teach, my teaching style, things like that. So thank you so much for joining me. I still appreciate all of the love that you guys give me. Someone said, do you still have the self-led CRC course? Yes, I do. I highly recommend that for those who already have their CRC certification. You can also take it, anybody, but that's when I highly recommend it. Sometimes it's just better when you have live instruction, someone to go over your things every week. So it just depends on your learning style. So yes, I still have it. I am updating some of the material. So it'll be also ready for registration or for sale on November the 15th as I do the updates. Because, you know, every year coding updates change. So I want to do some updates so you can have the most updated information. And if you know your learning style is one that you can listen and you can learn, you can write your notes. And of course, I'll still be accessible for questions. But if you know your learning style does that, the self-paced course will be great for you too. And it's $6.99 and it comes with a book. So thank you so much. Thank you so much for joining me. And you guys have a great night. Do you want to say bye to the TikTok people? You always want to say bye. Okay, you want to say bye to the TikTok people? Okay. Yeah, it sounds like a cat. Come and say bye to the TikTok people. He just love to say he the bye person. What you want to say? What you gonna say?
Bye, everybody.
Hey, everybody. So you know, me and my baby, you gotta have songs with your babies. Now keep in mind, I got a 22-year-old. 22. He'll be 23 in November. So 22-year-old, you don't even know. I had him. You don't know how old he is. You weren't even here when he was here. So I have a 22-year-old.
Well, I was born like
2017. Chris was born in 2001. You was never even thought about. Okay, so tell him good night. Tell him good night.
Good night.
I love my baby.
Baby loves.
You feel me? I can feel it. Thank you guys for joining me, and you guys have a good night.
Bye, everybody.
Bye, everybody. Yeah, I know how. Let me see.
Let me do it.
No, you be messing with my phone and stuff.